My name is Dr. Eliana Ramirez. I am the project director for the Crisis and Recovery Enhancement TA Center. We are here today for a cafecito with my esteemed colleague, Steven Samra from C4 Innovations. For those of you who haven't had an opportunity to see our cafecitos, the idea behind these short recordings is that prior to the pandemic, when more of us were working face-to-face with each other, we had an opportunity to run into each other in the staff lounge or around the proverbial water cooler. And that's where we tended to have some informal conversations that could really make a difference in the work that we did. Well, these days, many of us are not only working from home if we're privileged enough to have that option, but we're also experiencing some Zoom fatigue. And so logging on to the 60 or 90-minute session might be a little bit daunting. And so the idea behind these cafecitos is that it's a more of an informal conversation that we're having among colleagues. We're bringing in subject matter experts who can talk to us about different aspects of the crisis continuum of care and justice diversion in the state of California. And so today, as I mentioned, we have with us Mr. Steven Samra, who's going to talk to us about his experience, his lived experience, his expertise around peer specialist work, especially regarding stigma reduction. And if we have time, we'll talk also about reentry programs and justice diversion. And the last thing that I'll say before bringing Steven into the conversation here is just how timely this topic is for the state of California. Of course, we are in a very exciting moment when we are increasing peer specialist workforce across the state and across a variety of areas in behavioral health. So just with that as the larger context, I want to say welcome to Steven.
Eliana, thank you. It's such a pleasure to be here. And that new horizon for California is so exciting. And any way I can support that, you know that I'm here at the table to do so. So I'm happy to be here.
Well, it's been really fun getting to know you and working with you over the last couple of months. The CARE TA Center is funded by the Mental Health Services Act, and we are tasked to provide training and technical assistance, otherwise known as TA, to the behavioral health workforce in the state of California, the majority of whom are MHSA funded at a county level. And so we have a CARE TA Center that has 5 partner agencies. C4 Innovates is one of them, and that's where we are lucky enough to be connected to you through. And so you had agreed, Steven, to come in and talk to us a little bit about your own lived experience and your work as a peer specialist. So without further ado, I wonder if you would share with us a little bit about that lived experience, please.
Absolutely, I'm happy to do that. I could go in a lot of different directions with this, but I think the easiest way for me to sort of lay it out is to say that, and this is essentially what I share anyway, I have what I call the big 5 of behavioral health challenges. And my primary diagnosis, if you will, is an opioid use disorder. But I also have a serious and persistent mental illness. I've been diagnosed bipolar disorder. I have PTSD, I have anxiety, and I have severe ADHD. I'm also a trauma survivor. I have an ACE score of 9. So my childhood was pretty difficult. Excuse me. And that, of course, was exacerbated by poverty into adulthood. And we kind of know how that all plays out. I've spent enough time homeless in my lifetime to understand what it's like to live in a camp, what it's like to experience homelessness, and what it's like to try and extricate yourselves from that. And I'm a justice-involved individual as well. I was convicted in the 90s in California for a cannabis crime, a nonviolent cannabis crime, and actually went to prison and spent a couple of years in the penitentiary behind that. So I come to the table with that lived experience that sort of formed me and shaped who I was. But I did all that in active addiction, and I experienced much of the challenges in either full-on misuse of substances or outright addiction when I reached the point where opioids became the drug of choice for me. Um, I think the most important thing to say about all of that is I think a lot of times folks look at the addiction as fueling many of the challenges that were in front of me, including my mental health challenges, certainly employment and the things that really get impacted by addiction. But the truth is, for me, it was the addiction was a result of the mental health challenges I had that I was trying to medicate away. And we're going to talk much more about stigma here, but it's very clear that stigma stops most of us, those of us with behavioral health challenges, from even thinking about asking for treatment. And I can remember when I ultimately was court ordered into a counseling program as a result of my criminal behavior around cannabis. That in that referral, I was unable to explain to them what was compelling me to use. I couldn't describe that. I couldn't tell them this is why. But what I realized over time, and certainly over the period of my recovery, was exactly what I had said earlier. It has been my mental health challenges that have driven the self-medication, primarily because I might have been a dope fiend, but I'm not crazy. That stigma around mental health treatment, and even today now to substance use treatment, that kept me and many of my brothers and sisters out of treatment, and it still does that to this day. So I share that because I think stigma is one of those, probably the most important thing that behavioral health professionals need to understand as they are approaching those of us with the lived experience of addiction or mental health challenges or trauma or homelessness or all of the above. That it is the stigma that keeps us on the defense, that makes us view all of you with suspicion, and often is the reason we don't show up even when we've gotten appointments and you seemed helpful. It's the stigma that stops us. So I wanted to make sure that in my own lived experience, stigma was such a problem that it also was the reason I was unable to look at myself in the mirror. I had internalized much of the worst of the stigma that I'd heard about myself, to the point that it didn't matter whether or not I was. Let me see if I can give a better example. I am a person with an addiction. Addicts don't deserve help. Therefore, I don't deserve help. And I can flip that around. Addicts are bad people. I can't be an addict. So I guess because I'm not a bad person, so I guess I don't really need any help. Both ways got me to, sorry, no help for me today. That problem, it faces all of us with lived experience, particularly those of us who have co-occurring challenges. And we've been on the defense for a long time. We feel often persecuted, even when it may not be that way. And it's because of the role that stigma plays. So the access to recovery for me in 2000, I entered recovery in 1999, white knuckle recovery, because I have an opioid use disorder. And my goal was abstinence back then. In 2000, I entered a medication-assisted treatment program because the previous year, in that abstinence effort, I'd overdosed 3 times. And I'm only here today because each time I overdosed, I was around people who knew what to do. So that started my recovery. And it took me 5 years in the medication-assisted treatment program, and I was using methadone at that time. It took me 5 years before I realized that the drug itself, the medication, methadone, wasn't my recovery. It was just my treatment. And I didn't know how to do a recovery. I don't know what that means. And my 12-step my 12-step program that I was court ordered into in the 90s didn't want anything to do with me at the time because I had an opioid use disorder that I was going to use medication-assisted treatment for. So for that first 5 years in recovery, I wasn't really in recovery. I was just in medication management. And it was only through the process of learning about recovery that I began to both capitalize on my lived experience in terms of helping others along this journey, and the amount of epiphanies, realizations, self-reflections, they continue to this day, but it was as a result of being exposed to recovery principles, recovery successes by peers, that I began to want that. I wanted that. And I've not really wanted a lot of things in my life besides another fix. So this was something really new. And in terms of my lived experience, the most exciting thing was that for the first time in my life, I didn't have to think anymore. Well, if you really knew who I was, if you really knew, you wouldn't have anything to do with me. Because today, who you see and who you hear, that's exactly who I am.
Steven, it is so powerful to hear you share parts of your own history and lived experience. I have had an opportunity to hear you talk about pieces here and there, not kind of this arc of the story. And I know every time that I hear you speak, I'm experiencing a number of feelings. One is just deep gratitude and humility and respect that you would not only share such deep insights about yourself with colleagues, but about peer specialists in general, and how peer specialists can make such a difference and do make such a difference in undermining stigma, not just for consumers or clients or patients, whatever term people use for the folks who receive services, but also, and I think critically important, how much peer specialists, what a difference peer specialists can make among colleagues, among other behavioral health providers. And when I hear you talking about the relationship between experiences of mental health challenges, stress, trauma, and substance use, and the continuum to abuse as well, dependence versus moderated management, or whatever terms people might use. And then I step back and I think about where we are right now in 2021. Today's March 1st, 2021. We are however many months into this global pandemic. I don't know a single person who is not experiencing some stress. The stigma that many of us as mental health providers have in terms of being able to talk about the challenges that we experience, I think we can really look to peer specialists for the distinct leadership that you all can bring to this work, because you have oftentimes part of your recovery story is that honest self-assessment. Like you were saying that, okay, in the beginning, when you were on methadone, taking the methadone and thinking that the methadone was the recovery, and then realizing that wasn't the recovery. That was an intervention. That was a medical intervention that was preparing you, your mind, your body, your spirit, everything, so that you could then engage in the actual recovery work. Because of stigma, many behavioral health workforce folks are unable to have that kind of honest self-assessment and then even know how to use their own experience in an appropriate way with other clients, colleagues, consumers, heck, family, neighbors, anyone. So I really appreciate, again, that you would share in this kind of an honest way. And I wonder if you could talk a little bit more about what some of the distinct contributions are that peer specialists can make in that anti-stigma campaign. Specifically in terms of, well, I'll ask you three parts. One is, what kind of contributions do peer specialists make to anti-stigma campaigns in society at large? Then contributions to the behavioral health workforce. And then ultimately to us, that would be, what contributions do peer specialists make to the anti-stigma campaign in our own heads?
Yes.
If we're clients, consumers, if we're behavioral health specialists, what have you.
So Eliana, the around the society piece, I love that. I just really like this whole, set of questions because, it is absolutely true that many of us are not dying from our addictions and we're not dying from our mental health challenges per se. What's happening to us is that we won't come for treatment because of the stigma. And when that happens, we are in grave danger. And we've already seen that. We've seen that over and over and over, particularly in the opioid epidemic in this country. But it is certainly not going to be the last epidemic that this country faces. And so when you think about this in terms of that sort of society piece, at the societal level, you're dealing either with structural stigma or you're dealing with, public stigma. And both of those overlap, and both of those are designed and used to separate us from them. Whatever, whoever the us is and whoever the them is, that's the whole point and purpose of stigma. It is to categorize and then remove, right? So at the societal level, I think where people with lived experience, particularly peers, are able to move the needle, so to speak, is by being honest. It is by wearing these things that have happened to you on your sleeves and talking about them in order to normalize them. And the more that we do that, the more that I stand up and tell people, I went to prison for growing cannabis. I've lived in a homeless camp because I couldn't keep my job because I had an addiction that forced me to chase drugs around the back alleys rather than going to work every day. When folks hear that and then they look at the person who's talking to them and sharing those experiences, and that person appears to have been able to to be successful in spite of that, to have overcome many of those challenges, I think that shifts the paradigm for them a little bit. Because when you see somebody like me who has the history that I do, and that I'm not a, sort of a kind of a gibbering idiot and locked up in a jail cell somewhere, that in itself is, that's pretty miraculous. And so I think I have, and we peers generally have the power to show the larger community, look, we made some bad choices and we made some mistakes in our lives, but please don't distill us down to the single word addict. We are so much more than that. And if we do our recovery appropriately, if we are working together with good peers and good treatment professionals, because those two are complementary. This is not a competition, and we need the treatment folks just as much as we need the peer folks. When we work together like that, at the societal level, we send a powerful message that We can recover. We do recover. We should be expected to recover. Yes, we're going to need some support around that recovery. But if you provide that support, we will come. That's the society piece. If we're looking at this in terms of behavioral health challenges and behavioral health practitioners, we must grapple a bit with some implicit bias and with a lifetime of stigmatizing words and actions and efforts that are so now ingrained in many of us that we don't realize that we're stigmatizing when we're doing it. And so part of that challenge is, particularly in the behavioral health world, is to understand the kind of language that's coming out of your mouth, to remember that, what you say is often the first draft of what you're thinking. And you have a right and an ability to back up and, sort of reframe, rephrase as you need to. But if you don't know that the language itself is offensive, then how would you know to correct yourself? So I think there's a role for peers here, alongside behavioral health professionals, about changing the language and about auditing what we have as policies and procedures, because stigma invades all through there as well. Just like, structural racism is structural stigma. It's essentially one and the same. Both do grave harm to us, and I think this is the worst part. It also reflects completely back on the entire behavioral health workforce. Because if I can't get into treatment because I fear that I'm stigmatized by you, why would I come? Why would I come? So that behavioral health workforce, getting over the implicit bias, I think may be the most challenging, just because our treatment providers see us at our very worst, almost always. They see us at our very worst when we can be manipulative, we can sometimes be scandalous, we can be, there's a number of behaviors when you're in active addiction that I don't think any of us are very proud of. But they happen, and to say that they don't, I think does us all a disservice, right? And so again, this is where we need just brutal honesty about things. And if we don't have that, we've seen what, the last 70, 80 years of not being really honest about things, where that's gotten us. So at that behavioral health level, yeah, there's plenty of work we can do, but we really need to, I think, focus on implicit bias, think about, the impact of that bias. And frankly, you can't always throw out your bias, but you can suspend it. And you can set it aside in order to work with an individual who is sort of triggering your own bias. The reason that that's important is because as we deconstruct that bias, it's the same thing that happens to people when they see somebody that they thought was absolutely unable to recover in recovery and doing well. It is such a paradigm shift. It's such a bias basher that the power of it not only changes the behavioral health provider, but it pushes out that message by a behavioral health provider, which is much more important than hearing it from a peer in terms of who you're going to listen to as a colleague. It is that message that helps others slow their implicit bias, take a step back and maybe reconsider. And they can still hold that bias, but today they're watching and they're able to, again, set that aside and make a judgment or an assessment. I want to stay away from the word judgment, but make an assessment that, wow, this person doesn't fit all of the boxes and labels that I've had in my head about those, those individuals with substance use disorders, mental health challenges, trauma, etc. When we talk about that self-stigma, that one is the most powerful. And the reason it's the most powerful is because if you tell me all day long, Steven, you do a great job. Steven, you're valuable. We like you at this company. We love the work you're doing. What a great presentation, whatever it may be. I'll listen to all of you, but I don't believe any of that. And when I go home and I look at myself in the mirror, I don't hear all of you. I hear all that stigma over the last 50 years saying to me, you are worthless. And don't listen to any of that crap that those people say to you, because you know that if they really knew who you were, they'd not have anything to do with you. Now, I have been in recovery 20 plus years now, and I have been working on becoming a better human being for 15 of those 20 years. The first 5, I was just figuring out what life is like without having to chase drugs around the corner. But the last 15, I have been deep in reflection, deep in honest assessment of myself. I have really had to look at who I am, because here's the thing. When I entered recovery to me meant no more living the lies. I wanted to live ethically. I wanted to have morals. I wanted to be trusted. I wanted the respect that came with those things, with being an adult, with being a fully functioning and honest and appropriate adult, I guess. I wanted those things, but I couldn't believe that A, I could ever achieve them, and B, that I deserved them. And so the stigma at that internal level, that self-stigma, has, even to this day, stopped me from doing things that I'm certain I could do, but I'm scared to death of the stigma. I don't want people to say, oh, you stunk at that. That's so hurtful to me that I can't take that risk. I had to spend more time with my therapist and learning about trauma-informed care and trauma responses than I think I ever would have wanted to, in order to be able just to look in the mirror, Eliana, and not hate that person that looked back at me. And so today, I don't feel the love yet from my reflection in the mirror. But what I can tell you is that when I see him, I know today he's a good person, and he's okay. I'm still learning how to love myself, but the guy that looks back at me today is a good person. Think about that. 20 years. I have a high-end career. I have a master's degree. I've done everything that our society would expect a person to do. I've been wildly successful, and yet I can't look in the mirror and like the guy who looks back. That is the power of stigma. And it is why I honestly, I've dedicated my life to deconstructing this, to understanding what it does, and to teaching others how to do this as well, how to regain your sense of self, your sense of dignity, who you are, and to be able to stand with honor and respect and self-respect. Those are really, really important in a person's recovery. So I hope I got to all 3 of those areas for you.
You did. That was truly, truly remarkable. And it made me think of several things. The first of which is, gosh, well, 2 things. I'll share them both, and then I'd love to hear your thoughts and reaction to them, if they resonate or not, maybe as well.
Sure.
But the first is about hope. Peer specialists, kind of like part and parcel, left hand, right hand. One side is anti-stigma, the other side is hope.
Yeah.
It's about instilling hope. And this came through when you were talking about how behavioral health providers oftentimes see clients, consumers, patients, the community in the most challenging moments. So we don't get to see people when they're at their best. The second side of it was around the hope of recovery. And again, I just go back to 2020, 2021, and how for many people, the increased isolation that's happened this year can generate some of the difficult feelings, stress that we also experience when we go through other adverse experiences in life. Isolation is a part of depression. Isolation is oftentimes a part of trauma. Isolation is a part of rejection based on stereotypes and biases in society, right? So that the experience of being isolated for human beings who are naturally social creatures, and if we are being isolated from ourselves, looking in the mirror and having challenges, feeling love and empathy, valuing of who it is in front of the mirror in front of us, I just kind of thinking about, I think there's a way in which what you're describing is very common.
Yes.
And behavioral health providers may not be walking around with a label, like a diagnosis. That doesn't mean that these challenges aren't lived with and experienced. We know that for our medical health providers and our behavioral health providers as well, that substance use is a very common experience, a way of dealing with the massive stressors that are part of doing the work that we all do. And so again, this idea of how one is engaged in a professional setting, and then how one feels when they're by themselves looking in a mirror, can be kind of night and day from each other. And so again, this idea of hope is what I'm left with when you talk about your experience shifting about standing in front of the mirror. And at a certain point, it was one feeling, now it's another, and your eyes are still on the prize, which is at some point in the future, you can still get to another place.
Yes.
So I wonder, and then the final piece on my reflection on what you're just saying is how interesting that the imprint that can happen for us from a biological perspective from trauma, right? So our bodies learn to live off of stress hormones in a certain way. We react in a certain way to traumas, and then in the future anticipate a somewhat benign thing as being a risk of trauma, right? Of another trauma, is somewhat similar to what can happen in our heads with stigma. That when we are stigmatized, we learn to anticipate stigma in the future again, in the same way that we learn to anticipate trauma from happening. And these are actually, one way you could look at it is these are really well-developed defense mechanisms.
Yes. Yes.
And maybe if we don't, and maybe if we don't pathologize them, but maybe if we approach them with a little bit of compassion towards ourselves and kind of towards each other and think about it in that way, we can save ourselves some pain. But that last point makes me think about how I don't know a single person, and I've been in the world of social work for decades now, I don't know a single person who entered social work, psychology, nursing, medicine, any one of these fields to do anything besides help other people. That's why we enter these fields.
Yes.
And to learn that the stigmas that we walk around with towards ourselves and towards other could actually be causing harm without our awareness of it. So you're talking about that unintentional bias. And this brings me back to why it's so important for us to work alongside peer specialists. Because peer specialists can teach us something that is not in the textbooks. And most oftentimes is not even in the minds of the professors who are teaching us in front of the classrooms. And so just makes me reflect on, again, peer specialists can bring hope right alongside of anti-stigma, and that it can make a difference for clients and consumers, but it also can make a difference for our colleagues. The final question that I'll leave you with here, and we've got just like another 2 minutes really to kind of talk about this, is can you share any ways that peer specialists can affect the behavioral health services and systems in terms of anti-stigma and hope?
Just our presence, just showing up for work as people in recovery with a laundry list of lived experiences is hopeful. That alone should be saying to our my colleagues in the behavioral health system, holy cow, look at what is possible. Now, folks like to say, they use the term resilience a lot, and I'm okay with that. But here's the thing with resilience: every time I hear that, I just want to duck, because I'm worried about what else is coming my way. And because people think I'm resilient, they think I can handle anything, right? I can't. And I understand that I am resilient, but we need each other, and we need people who have been through this before, who have extricated themselves, who have found that recovery path, and who can stand in front of behavioral health providers, our community members, each other, and say, warts and all, here I am, recovery is possible, I'm living proof of that, and please don't distill me down to that one thing that I've been struggling to get away from for the last 10, 20, 30 years, whatever it may be, because I am far more than that. And when you talk about hope, that is one of the most important pieces for me, is that there is hope for something better in my life, better in my soul. That part is really, really important. But what I often tell people is, especially those folks, my brothers and sisters who are really struggling still and don't have any hope, I'll carry that hope for you until you're strong enough to carry it by yourself again. But I expect you to carry somebody else's hope down the road in your recovery. So that part, that piece of hope, that does more to motivate us than perhaps anything else that the behavioral health community, the peer community can put in front of us. If we believe, and if we actually have people who believe with us that recovery is possible, that I may have done these things, but that's not who I am, and that oftentimes, while we're responsible for our behaviors and the things that we've done, when you think about the brain changes of trauma, when you think about the brain changes of an opioid use disorder, much of what we've done has not been our fault. We're responsible, but it's not our fault. And the moment that you hear that, at least for me, when I realized that, that was the first time I could look in the mirror and not hate that guy looking back. And I'm still working on, as I said earlier, loving that guy. But at least now I can see him in the mirror and I'm not revulsed. That's a huge, huge change for me.
That resonates so strongly in thinking about then a behavioral health service or system. When a behavioral health service or system is staffed by people who live and breathe recovery, who live and breathe a sense of hope, it's a different kind of system. It becomes a different kind of system. Yes. So when we start to think about discharging people from programs, when we start to think about the possibilities for community integration, for community reentry. It's a very different potential future if we're looking through the lenses of hope and possibility, rather than through the framing of the moments of the greatest distress and making decisions based on a sense of fear, anger, whatever else might lead to the difficult decisions that people sometimes make that later on that they may not feel good about.
You've nailed it. And one last thing, because I think this is really important. What you're seeing in many of us, particularly those of us that are either very early in recovery or, sort of contemplative about it, is that you're getting our best maladaptive coping mechanisms, right? That's what you're getting. And when we move those coping mechanisms that we've had in our subcultures that we've been engaged in, and when we move them into the larger community, they don't go over very well. And those maladaptive coping mechanisms are what people see, the behavioral health professionals see all the time. And of course, that would create some bias. I understand that. The trick is, I think the key, honestly, is helping us deconstruct some of those maladaptive coping mechanisms too.
I appreciate you saying that. And I think that part of what I have always benefited from in working alongside multiple, not just one peer specialist, but I've seen the greatest impact on agencies and systems when there's more than one peer specialist, frankly. Because who wants to be a model minority for anyone in any time, right? Exactly. We have the best chance of having positive outcomes, and we have a force of people. Yes. Is that the medical model, which is of course a medical model because the Diagnostic Statistical Manual and all of our funding, whether it's Medi-Cal or Medicaid or any other source of funding, is tied to diagnoses, is tied to certain kinds of interventions. So of course it's medicalized. And it's also value laden in ways that is not necessarily coming from a place of hope or unconditional love or grace or any of these things that we know are so important for changing the trajectory of one's life or one's system or one's team or one's agency or frankly one's society.
Yes.
And so I think that there's a way in which my experience, at least as a formally trained social worker, is that I'm having to unlearn some of the biases that are inherent in learning how to use the Diagnostic Statistical Manual. And just one quick example of this, and I know we're at our time, one quick example of this is a colleague of mine that I always mention. She's a peer specialist. She's a Black peer specialist. She talks about being in a locked psychiatric facility and going up for review. And this was, I think, somewhere in like the mid to late 90s, but going up for a review essentially in front of the head psychiatrist, who's going to look at her and determine whether or not she is better enough to be discharged back in the community. She did not have access to the kinds of hair products and skincare products that she needed to present in a way that her white psychiatrist would see her as being what the Diagnostic Statistical Manual would identify as like well kept.
Yes.
And so again, it's like our biases, whether they're based on our own individual experience of race, culture, ethnicity, or they're based on our training as mental health professionals using the Diagnostic Statistical Manual, we don't necessarily know how the lenses that we're looking through are creating biased perceptions of others. And so that's what we can learn so much from our colleagues. Gosh, Steven, thank you so much. I'm going to have to invite you back. Whether or not you accept that invitation is up to you, but I just feel like there's so much more that we can chat about together. I am so grateful for the work that you do and for your honesty in this presentation. I am certain that others are going to find it to resonate in their experiences. So thank you, Steven. I hope you'll come back again.
It is my pleasure. I will come back anytime, Ileana, and thank you for having me. It's been a joy.
Wonderful. Well, thank you all to our audience and stay tuned for our next episode of A Cafecito. Thank you. Take care.